Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bauer, the editor of GP Online. Today on the podcast, I'm talking to Dr Lisa Harrod-Rothwell, who's the Chief Executive of Londonwide LMCs and a GP in Islington, North London. Londonwide LMCs represents local medical committees, GPs and practices in 27 of the capital's 32 boroughs. In this conversation, Lisa explains exactly what Londonwide LMCs does and some of the key challenges facing general practice in London, including workforce issues, premises problems and health inequalities. She also talks about the London region of the NHS's vision for a neighbourhood health service and the role Londonwide LMCs has played in shaping that plan. We discuss the importance of general practice being at the table for planning discussions, the need for a function-first approach to service delivery, and the potential for a neighbourhood NHS to support and value general practice. Lisa also shares her priorities for the next year as CEO, which are focused on empowering and valuing GPs and practice teams in London. I'm really pleased to welcome onto the podcast now Dr Lisa Harrod-Rothwell, who is the Chief Executive of Londonwide LMCs. Lisa is a GP in Islington in North London and also a trustee and volunteer GP for Doctors of the World UK. Lisa became CEO of Londonwide LMCs in May this year, having previously been the Deputy CEO. Thank you so much for coming on the podcast, Lisa.
Thank you so much for inviting me. I'm delighted to be here.
Can you explain a little bit about who Londonwide LMCs cover, what you do as an organisation, how you fit in with the local LMCs in London?
Yeah, absolutely. So local medical committees represent local GPs. They express their insights, their experiences, their concerns, and they work with stakeholders to try and address the issues. So in London, we also have an umbrella organisation, Londonwide LMCs, that supports the LMCs in our 27 boroughs of London. We also provide support directly to our practices and our GPs. And because of our scale, we're really lucky to have a lot of expertise sitting across London-wide. We have commissioning expertise, contractual expertise, regulatory expertise, some legal expertise, communications, media handling, you name it, we've got it. So the offer that we can provide to our practices and to our GPs and to our local medical committees, I'm really proud of.
And how did you yourself get into medical politics? What made you want to get involved with LMCs?
I think I'd been in medical politics for a number of years before I realised I was in medical politics. I've always been the type of person who wants to fix things that are broken. I always get really frustrated when people tell me that's just the way it is. You can't change that. Because my first question is, why not? I was getting frustrated in my surgery about the wider system issues. And this was not long after I'd qualified. And I happened to notice a letter from the Chief Exec of Essex LMCs inviting people to stand for the local medical committee and explaining what they did. I just thought this was such an exciting opportunity to get involved and actually try and fix some of these things. So from Essex LMCs, I then went into commissioning. But 9 years ago, I almost came back to my roots at Londonwide LMCs as the Deputy Chief Executive. One of the things I really value about LMCs is that we don't toe a party line. If something is wrong, we can call it out without fear of our jobs, without fear of retribution. I think it's really difficult on the commissioning side. I think it's really difficult with the financial constraints where you're having to make very, very difficult decisions, some of which potentially can result in unsafe care. On the LMC side, we can call that out. And I think that we have very, very significant impact.
The London region of NHS England recently published its vision on how it was going to create a neighbourhood health service in the capital. It said that London was experiencing a perfect storm in which deep-seated economic and health inequalities were driving ill health, resulting in increased pressure on the NHS. And it did highlight that London was particularly severe when it came to challenges in general practice, even compared to other parts of England.
I think it's absolutely fair that deep-seated economic and health inequalities are driving ill health. Of course, ill health drives pressures on services, and you can create a vicious cycle. But that narrative is way too simplistic. And that narrative absolves senior decision makers in their part in exacerbating that vicious cycle. Inequalities are complex, but they're also preventable. And the pressures on the NHS aren't just down to increased need. It is utterly incredulous that practices in England that serve the most deprived areas, where you can have the greatest impact, receive less funding.
What are some of the particular issues in London that cause problems for practices? What are they and how do they affect practices?
So not only do we have health inequalities, we also have a workforce crisis, and we have some of the worst workforce data across the country. That has a very, very significant impact on ability to deliver care, on outcomes, on patient satisfaction, and of course on retention. And of course, the other issue that we have in London is premises. It is really difficult to deliver high quality care if you don't have appropriate premises, appropriate rooms, etc.
Why do you think London has got a bigger problem with the workforce than perhaps other places have?
So I think that some of it is down to the funding issues with areas with greater need. Obviously, if you have a practice that has fewer members of staff, those members of staff are having to work harder. And we know that across the country, irrespective of levels of deprivation, everybody is already working under immense pressure. Those areas, therefore, find it harder to recruit and to retain staff. That is a key issue. Of course, also living in London, there's a higher cost of living, and we do see people move out to the home counties and other places after training because of the cost of living. But London is a great place to work. The diversity that we see within our practices is really interesting, and you really do feel that you can make an impact and really understand your local communities and some of their health beliefs and their values and what matters to them, and then alter your care to meet their needs in that way.
You are right, though. The cost of living is a real problem in the city. And obviously the premises issue is tied to that as well, isn't it? Because it's the cost of property that really is causing a lot of the premises problems that GP practices face. What do you think needs to be done to sort out the primary care estate in London?
Oh, my goodness me. I wish I had the answer to what we can do to solve that problem.
There's a whole podcast in that, isn't there?
We do have some money coming down for premises. We absolutely need to make sure that money is utilised in the right way, is managed and prioritised and allocated in the right way. This is really, really tricky because it is really important for effective general practice to be embedded in local communities. That social capital of the practice where everybody knows it, most people can walk to it. It's safe, it's familiar, it's people's own practice with their own doctor. I am not an advocate of moving GPs out of that really embedded place in local communities and putting them in big health centres at all. But I do recognise that we do have constraints. With the new GP contract, which it enabled us to recruit different members of staff, there was no premises planning for that. There was no consideration of where we were going to put these new members of staff. And consequently, the experience of premises with additional members of staff hasn't been positive. We've had people displaced. We've had people now who have no choice but to work remotely when face-to-face care is still really, really important. We've had issues with not being able to form teams effectively because we're not coming together. But certainly we absolutely need a strategic plan around this that still enables general practice to deliver safe, effective care embedded in local communities. There is still a role for a health centre type approach, for a hub type approach, particularly when we're looking at general practice at scale and the services that general practice at scale could offer. But that is a separate function to the function that GPs deliver through practices.
General practice in London is as diverse as the city itself and the people who live here. You do have practices that are housed in really wonderful modern buildings. And then you have a lot of very small practices with like 1 or 2 GP partners, don't you? What's the kind of makeup? Are practices getting bigger? That's the general trend we've seen across the country. Or in London, have you still got quite a lot of those sort of single-handed, smaller practices?
We have the full range of practice size in London.
Yeah.
Generally, the way that practices deliver services depends on the population they're serving. And that is one of the real beauties of the practice level delivery, of being embedded in local areas, in local communities, and that clinical leadership and the autonomy to deliver services in the right way. So quite often when we see a small practice embedded in a community, the GPs and the staff will be members of that local community. They may well speak the language of a local community. They understand the value system of that local community. We would really, really be losing something very important if we overlook that. By the same token, we have very large practices, lots of single contracts with lots of different sites type model across London.
Coming back to that neighbourhood plan, right, because that was really interesting. That's a really big document, well, 2 really big documents actually, that came out a couple of months ago looking at how to develop this whole idea of a neighbourhood NHS in London. Londonwide LMCs was sort of involved with shaping that plan, weren't you? What exactly was your role in all of that?
We were definitely involved in shaping that plan. And I think it's really important in any of these planning discussions that general practice is around the table. I've had a really positive experience so far of being involved in this work. I really feel that I have been brought round the table and that general practice has been recognised as a key player. My role has been really interesting. So the first thing is making sure that all system partners are aware of the role of the GP, making sure that they're aware of the role of the practice, making sure that they're aware that the role of the practice is different to the role of at scale, trying to dispel any misconceptions that people have. For example, there's been such a drive for at scale general practice that the role and the value and just how important the practice level delivery seems to have been overlooked or is undervalued. I've also been able to help system partners understand the constraints that general practice operates under. So again, this addresses a lot of misconceptions. Throughout this process, I have heard people say, but that's the job of the GP. And frequently I've said, we're not contracted to offer that. It's actually not our job. Also to challenge some of the cultural elements. So we hear of waits in A&E and we hear of pressure on A&E. We hear of pressure on hospitals and waits for outpatient appointments and for mental health services. We hear of the increased demand on other services. We have the conversations of how do we get the waiting list down? How do we reduce the demand? When people talk about general practice, they're not asking the same questions. We have a very, very, very significant demand capacity mismatch, arguably a much bigger demand capacity mismatch than anywhere else in the system. What we hear is that we have a struggling practice, or worse, we have a failing practice. And then the question is, what do we do about the failing practice? Who's going to support the failing practice? And I'm really, really, really keen that we change this, that we recognise that there is a demand capacity mismatch across the whole system and that we treat every part of that system with equal parity of esteem. The discussions that I have been having, I'm really optimistic that general practice will be able, certainly at a regional level, come to the table with parity of esteem.
So would you argue that in London you need to keep the small practices but have some overarching at-scale structure? And how do you see that working in reality? Is it just PCNs as they are now, or does that need to change as we move towards a neighbourhood NHS?
I'm not saying that there needs to be an overarching structure because that implies some form of hierarchy. There are different functions that general practice and the wider primary care can offer, particularly in the context of moving care from hospitals into the community. The scale and the type of service that needs to be provided will be dependent on the function of the service. If we're talking about mental health reviews, for example, then that continuity of care, that holistic care, that familiar environment, seeing your own doctor, potentially is really important. If we're talking about offering a ring pessary service and you work in an area where the demand for ring pessaries isn't that high, it doesn't make sense from a staffing perspective to necessarily run a clinic. It probably makes more sense to offer that at scale. It has to come back to function, and then we have to look at the appropriate scale. And that's the same if we start thinking about moving services from hospitals into the community. So it has to be related to the needs of local populations. And this tendency to oversimplify things and say, well, it's PCN level or it's this level isn't particularly helpful. So we have to keep going back to function before form. It's really, really important. If we're going to make this shift and we're really going to build the community offer and keep people at home and embrace prevention and the complexity that our patients have, and we're going to manage that in the right way, we've got to get away from at scale, and then defining what that at scale is.
Do you get the sense that system leaders and ICB people who are going to be in charge of doing all this strategic commissioning as we go forward, do you get the sense that they really understand that?
Many of our commissioners are excellent. I am concerned around the national direction of travel and some of the national messaging. This comes back to a really basic principle. The decisions that should be made by those closest to the problem. And as soon as you start detaching the responsibility for the solutions from those who understand the problem, you've got an issue. And we see that time and time again at all levels. So, for example, at practice level, we've just talked about the importance of being able to bespoke your offer to meet the needs of your local community. As soon as a commissioner, even if that's at borough level, starts stating how patients should access your services, you've created inadvertent problems. We do have some problems in North West London because they have chosen to contract all of their services through the PCN. And I understand that that's more convenient. But that creates some difficulties because not every single service within that one offer is appropriate for all of the populations of every individual practice. It doesn't enable practices to bespoke their offer. The people closest to the problem need to be responsible for the solutions. They need to be given the headspace to work out what those solutions are and collaborate with other people close to the problem, and that includes the patients. And then the strategy and contracts and the policies and the regulation and everything else, then that needs to be aligned. To have a blanket one-size-fits-all, here's your contract, here's the policy, and then scrabble around on the ground to try and make that work for your local populations is just absolutely nonsensical. But we do see that, unfortunately, time and time again.
Yeah, it's interesting. That North West London one, we've written about that. What they've done there, isn't it? They put all of the local enhanced services effectively into one big basket. Part of the reason for doing it was kind of to standardise it across the CCGs that kind of all came together to form North West London ICB. But as you said, North West London is a massive area. One of the things I've talked to people about recently is about the difference in local enhanced services across England. Do you find that there's a really big difference in the local enhanced services, the payment rates and what people are getting across London?
We do have a lot of variability. As you say, the variability is reducing and has reduced with the mergers on the commissioning side. But the funding historically per area is hugely variable. And it's really hard to equalise because if you're pulling money out of one area suddenly, you have to modify all of your contracts, all of your infrastructure. You have to change patient expectation. So it's actually quite complex just to equalise across boroughs, which historically have had incredibly different funding levels per person head.
Just coming back to that neighbourhood plan, you said you've been quite encouraged by conversations you've had around that. But one of the things I thought that was quite interesting about that London neighbourhood plan is general practice seemed to be mentioned a lot in it. And there was also recognition that some practices are really struggling. There was talk about the fact the need to make this move to neighbourhoods to kind of almost protect and shore up general practice. Do you think this move towards a neighbourhood NHS will help general practice in the longer run?
I'm optimistic. Moving care into the community and supporting that care, I think, is absolutely right for patients. I think it's right for communities. GPs and practices have such a fundamental role in that. We already deliver care in the community. We're the coordinators of care. We understand how the different system works and the services that our patients need. We know which services our patients can't access. We know the challenges. We get feedback from some of the pathways. We have the expertise and we're absolutely well placed to be able to drive some of these changes. Having the opportunity to have a model of care that works for the current patient complexity and having the opportunity to address the day-to-day frustrations that we experience as GPs because the system is siloed and it doesn't work together and the systems in place don't work for people working within the system, nor our patients who are trying to navigate different services. Having the opportunity to address those is all really, really exciting. If we can achieve that, it will absolutely help general practice. At the moment, we spend a lot of time filling in forms that aren't fit for purpose, that you can't edit, that when you do edit, the formatting doesn't work. You send it off, it gets sent back to you. It wastes so much time. And our patients are too complex for us to impart the clinical information that we need through a form. Quite often what we need is the opportunity to discuss with other members of the team so that we have a shared plan. And we're sharing the risk and uncertainty that creeps in when you have complex care and lots of comorbidities. In terms of supporting practices, I estimate that about 1/4 of my encounters with patients should never have come to me. I was not best placed to address them. I'm not contracted to address them. Sometimes others are contracted to address them and they're the ones sending them to me. Sometimes there's just no service and I'm trying to do my best for the patient in front of me. If you take that workload away from me, you've supported me and suddenly my day is doable. Might even bring me some joy. So if we're really looking at how practices can be supported, it's not vertical integration and taking over contracts. It's not making practices merge and making them form at scale, because that won't solve the problems. This concept that you've got a workforce issue where you don't have the right capabilities and capacities because of the funding, and then if you merge practices, you can resolve that workforce deficit. Who actually believes that's true? It doesn't make any sense at all. But let's talk about supporting general practice, but let's actually talk about how general practice can really be supported and valued and not undermined and allowed to thrive.
One of the things I noticed in that plan as well is it said that there needed to be a consistent approach to developing neighbourhoods across London. And we haven't really touched on this, but just to people who outside of London might not realise this, but London it's absolutely huge, isn't it? I mean, we're talking about 32 local authorities, 22 acute and specialist hospital trusts, 10 mental health trusts, it's hundreds of PCNs. It's quite a big ask to do this in a consistent way. Do you actually think that that's possible, so it works in the same way across the capital, or is it even necessary?
So with the work that's being done at the moment, there is no plan to impose a one-size-fits-all.
Right.
What we're trying to do at a regional level is set a series of principles and also think about what can be offered across London to support the development of these plans. The trouble with INTs is that in the fuller stock take, and they've become policy, commissioners have been told they need to implement INTs. There is no definition of an INT. So what we've got at the moment is some really, really good work of INTs being set up across London, but they're doing different things. They have a different purpose, they've been set up in different ways, they involve different people. And the London work aims just to try and put some principles around what an INT can do and the support that needs to be put in place to enable integrated working. We shouldn't really be talking about integrated neighbourhood teams because patient care is too complex for us to have a team. What we're talking about is neighbourhood working. We're talking about collaboration. We're talking about different ways of working. And we're talking about teaming with different people depending upon the context. It's quite complex to get your head around in terms of the full opportunities that working collaboratively and working in a more integrated way can offer. But this comes back down to the responsibility for finding the solutions needs to be given to those closest to the problem. And depending upon the problem, depends upon the scale that you go down to and the provider level that you go down to address that problem. We are really trying on the ground. Our local medical committees are now, so what have been involved in the regional work, but our local medical committees now are heavily involved in these discussions at borough level. You know, how can we really make this work for our local population? What's the greatest need? How can we add the most value through working differently? And those discussions are now starting to happen. In addition to some of the really good work that, you know, has taken off already in some parts of London.
That plan sort of suggested that primary care networks might need to realign around neighbourhoods. Do you think that's something that's going to happen? Do you think they'll need to be sort of geographically aligned?
I think it's always difficult between the NHS and local authorities and boundaries. We saw some conflict in a minority of areas in London when PCNs were forming because the requirements of the national contract didn't match local authority boundaries. That said, I don't anticipate a big wide-scale change unless there is a significant contractual change. Because at the moment, obviously, practices are funded to work at this scale in this way with this configuration. I can't preempt what might happen contractually. I hope that there is enough recognition across the system that PCNs, whilst many of them had a very difficult start to life, actually are delivering some really good services now. And there would need to be a thorough risk assessment and mitigation plan if they were looking at changing those boundaries.
One of the things it did talk about was about the fact that the NHS in London wants an integrator organisation, as they called it, sort of drive forward all this integration. And obviously, because of the timeframes involved, it was saying that this would most likely be an existing organisation. It also sort of mentioned that those integrators would be expected to support struggling practices. I mean, how do you see that working? Who do you think, which organisations are likely to be those people who are driving forward neighbourhood working?
Yeah, certainly footprints and the integrator are the two of the areas that are causing the most contention on the ground at the moment. And there's a lot of speculation about the integrator provider and the integrator role. There's also a big pressure across London to decide which provider is going to do that in each borough, even though the role hasn't really been defined yet. And of course, we're awaiting the 10-year plan, which could turn everything on its head. It feels somewhat counterintuitive, doesn't it, that hospitals that don't particularly work in the community space, don't occupy a coordinator role within patient care and operate on a very medical model would be best placed to integrate services in the community. From a function perspective, that doesn't make a huge amount of sense to me. But there is no money to do this. And hospitals have money and they have power. So I can see that hospitals and some of the other sector larger providers would want to move into this space. Whichever organisation ends up being the integrator, assume that's consistent with a 10-year plan, they would benefit from having a partnership with general practice because general practice has the expertise. So I think it has to be considered very, very carefully. And I think general practice will need to step up and will need to support this function. what would be a real shame, having the intent to move services into the community, having the intent to address health inequalities, having the intent to be much more holistic and bring in the voluntary sector and really focus on prevention and the wider strengths of health. What would be a real shame is if this were led by people who only have experience in the hospital model of care. So general practice has evolved over the years to be able to meet the needs of patients with long-term conditions. There are so many brilliant ideas around how we can really embed and get a model that's fit for purpose across all services moving forward. So if this does end up being a vertical integration type approach, we would really have, well, not only missed a trick, but we would send the NHS backwards if we continue to adopt a medical model.
How do you think the GP contract needs to change then? Obviously, that's coming down the track in the next few years. What would you like to see in that?
It's really difficult to consider a GP contract in isolation from other contracts.
Yeah.
Because contracts drive system provider behaviour and prioritisation of resource. For example, in hospitals, if you've got an activity-based contract, we see rapid activity, but only in the areas that are funded. If you've got an all-you-can-eat buffet contract, you have a different approach to deploying your staff. What really needs to happen is we need to design the model of care. We need to understand how services are going to work together. We need to understand the resource constraints. We need to have open, honest discussions with the public about what can be afforded and what can't be afforded, and we need to get their views into how we prioritise and how we ration. That rationing word needs to be out there and in the open, and we need to engage with our local communities and our populations. Once we understand what the service model looks like across all sectors, all providers, then we start thinking about distribution of funding. Then we start thinking about how we contract that at the right scale to deliver those services.
Yeah.
Just to design a contract in isolation would be very unhelpful.
We've talked about the workforce problems in London. Is the GP jobs crisis a problem in the capital as well? Because obviously, underfunding is still a major issue for general practice in London.
It's a big issue. But it is a national issue.
Yeah.
But because of some of the additional pressures and challenges across London, some of our practices are really at the sharp end of that. And that's borne out in our GP patient ratios, which are in some areas are amongst the highest in the country. We have a demand capacity mismatch. That has been managed nationally by introducing an additional roles reimbursement scheme. But because of the funding constraints, in many areas, this is not an additional roles reimbursement scheme. It's a replacement roles reimbursement scheme because practices can no longer afford to replace GPs who leave. If our additional roles, if our mental health nurses, our paramedics were in addition to GPs and we had the right GP patient ratio, that would be great, but we don't. So at a time when patient care is more complex than ever before, at a time when the NHS really needs that gatekeeper role, it really needs the expertise to be able to handle clinical risk and uncertainty, we have seen a change and a dilution of the GP capability across the country. I think it's been really, really short-sighted, and consequently, the challenges of working in general practice are immense. We know that many of our GPs are anxious before they go into work. They're anxious they're not going to be able to manage the demand. We know from our workforce survey that the majority of GPs in London don't feel able to practice safely anymore because of the demand capacity mismatch. I mean, that is really, really extreme. These things are down to senior decision maker choices that have been made in terms of the funding between different parts of the healthcare system, between what they have valued in our contracts. I really do hope that we can redevise a model of care that enables GPs to do what they trained to do, because patients want and need that. We're trained to deliver that. And at the moment we can't. Because the demand capacity mismatch, we've been pushed much more into a transactional model of care. The online consultations has pushed us into the medical model of care. we're losing that continuity, we're losing that holistic approach that we know saves money, we know gives patient outcomes, we know gives patient satisfaction. We really, really need things to change.
Just before we finish, what are going to be your key priorities over the next year or so as Chief Executive of Londonwide LMCs?
So I'm really excited to be in this role, and we are embarking on an exciting and important journey. We're currently doing a full review of our services. We want to be able to truly listen to our GPs and our practices. We want to understand what's working for them, and we want to reimagine what can be even better for them and how we can support that. This is a real opportunity for us to shape the future of our support and ensure it meets the realities of the front line. And I am genuinely energised for where this organisation can go. We have the chance to uplift and empower our GPs and practice teams. We want them to be able to deliver outstanding patient care, both at the practice level and at the at-scale level. And I really want to restore the professional pride and job satisfaction and morale that unfortunately has been lost in recent years, because general practice is one of the most rewarding jobs. And despite all of the challenges and constraints that we currently operate under, GPs and their teams are amazing. And we are the most cost-effective part of the healthcare system. After all the denigration and undermining of recent years, I want GPs to reclaim their professional esteem. I want them to really stand tall in the value that they bring to patients, families and communities every single day. And I want to do everything I can to make sure that our GPs and their teams and the wider system all recognise that again. And it's such a privilege to be doing this job, because there is the opportunity to work towards that. And I've got an absolutely fantastic team behind me who are all keen to do just that. So, as I say, it's a really, really exciting role for me, a really exciting time.
All right, that's a really positive place to end it on, Lisa. Thank you so much for coming on the podcast.
Thank you very much for having me.
Well, that's it for this week. Thanks again to Lisa, and thank you for listening. I'll be back next week for our regular news review, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access a wealth of other resources and information on our website at GPonline.com.